Part 2 of Addison's disease. Nursing intervention. When the patient with Addison's disease is hospitalized, nursing management is focused on monitoring the patient while correcting fluid and electrolyte imbalance. Assess vital signs and signs of fluid volume deficit and electrolyte imbalance. Monitor trends in serum glucose, sodium, and potassium levels. Establish baseline data regarding mental status, vital signs, and weight. Obtain a complete medication history to determine potential drugs that can interact with corticosteroids, anticoagulants, and NSAIDs. Note changes in blood pressure, weight gain, weakness, or other manifestations of Cushing syndrome. In addition, protect against exposure to infection and assist with daily hygiene. Protect the patient from noise, light, and environmental temperature extremes. The patient cannot cope with these stresses because of the inability to produce corticosteroids. Patient teaching regarding drug administration. Glucocorticoids are usually given in divided doses, 2/3 in the morning and 1/3 in the afternoon. Mineralocorticoids are given once daily, preferably in the morning. Hydrocortisone contains both glucocorticoids and mineralocorticoids. Fludrocortisone has only mineralocorticoids. This dosage schedule reflects normal circadian rhythm in endogenous hormone secretion and decreases the side effects associated with corticosteroid therapy. Patients with Addison's disease are unable to tolerate physical or emotional stress without additional exogenous corticosteroids. Long-term care revolves around recognizing the need for extra medication and techniques for stress management. Examples of situations necessitating corticosteroid adjustments are fever, influenza, extraction of teeth, and rigorous physical activity such as playing tennis on a hot day or running a marathon. If vomiting or diarrhea occurs, as may happen with influenza, notify the healthcare provider immediately because electrolyte replacement and parenteral administration of cortisol may be necessary. Overall, patients who take their medications consistently can anticipate a normal life expectancy. Teach the patient about the signs and symptoms of corticosteroid deficiency and excess, which would mean Cushing syndrome, and to report these signs to their healthcare provider so the dosage can be individually adjusted. It is critical that the patient wear an identification bracelet and carry a wallet card stating the patient has Addison's disease so that appropriate therapy can be initiated in case of an emergency. Instruct patients using mineralocorticoid therapy, which is Florinef or fludrocortisone, how to take their blood pressure every day and to report any significant changes to their healthcare provider like weight gain, edema, and increased blood pressure. The patient should carry an emergency kit at all times. The kit should consist of 100 mg of IM hydrocortisone, syringes, and instructions for use. Instruct the patient and significant others how to give an IM injection in case the hormone therapy cannot be taken orally. Have the patient verbalize instructions and practice IM injections with saline. Provide written instructions as to when the dosage should be changed. A beneficial effect of corticosteroids in one situation may be harmful in another. For example, decreasing inflammation in arthritis is an important therapeutic effect, but increasing the risk for infection is a harmful effect. Suppression of inflammation and immune response may help save lives in persons with anaphylaxis and in those receiving an organ transplant, but it causes reactivation of latent tuberculosis and greatly reduces resistance to other infections and cancers. The vasopressive effect of corticosteroids is critical in enabling a person to function in stressful situations. but this effect can produce hypertension when used for drug therapy. Hypokalemia may develop. Hypocalcemia related to anti-vitamin D effect may occur. Glucose intolerance predisposes to diabetes mellitus. Blood pressure increases because of excess blood volume and potentiation of vasoconstrictor effects. Hypertension predisposes to heart failure. Healing is delayed. There is increased risk for wound dehiscence. Susceptibility to infection is increased. Infection develops more rapidly and spreads more widely. Manifestations of inflammation, including redness, tenderness, heat, swelling, local edema, are suppressed. Predisposition to peptic ulcer disease develops. Skeletal muscle atrophy and weakness can occur. Mood and behavior changes can be observed. Fat from extremities is redistributed to trunk and face. Bones are made up of protein matrix. The protein depletion decreases bone formation, density, and strength, leading to predisposition to pathological fractures, especially compression fractures of the vertebrae due to osteoporosis. Calcium excretion by the kidneys also decreases skeletal mass and bones become weaker. Corticosteroid deficiency is likely if hormones are withdrawn abruptly. Therefore, always taper corticosteroid doses gradually. When corticosteroids are used as non-replacement therapies, they are taken once daily or once every other day. They should be taken early in the morning with food to decrease gastric irritation. Because exogenous corticosteroid administration may suppress endogenous ACTH and therefore endogenous cortisol, emphasize the danger of abrupt cessation of corticosteroid therapy to patients and caregivers. Corticosteroids taken for longer than 1 week will suppress adrenal production, and oral corticosteroids must be tapered. Ensure that increased doses of corticosteroids are prescribed in acute care or home care settings in situations of physical or emotional stress. Corticosteroid-induced osteoporosis is an important concern for patients who receive corticosteroid treatment for prolonged periods of time, longer than 3 months. Therapies to reduce the resorption of bones may include increased calcium intake, vitamin D supplementation, biophosphonates, for example, alendronate or Fosamax, and institution of a low-impact exercise program. Include instructions on dietary needs to patients. Plan a diet high in protein and calcium, at least 1,500 milligram per day, and potassium, but low in fat and concentrated simple carbohydrates such as sugar, honey, syrups, and candy. Identify measures to ensure adequate rest and sleep, such as daily naps and avoidance of caffeine late in the day. Develop and maintain an exercise program to help maintain bone integrity. Recognize edema and ways to restrict sodium intake to less than 2,000 milligram per day if edema occurs. Monitor glucose levels and recognize symptoms of hyperglycemia, example polydipsia, polyuria, and blood vision. Report hyperglycemic symptoms or capillary glucose levels exceeding 120 milligram percent. Notify healthcare provider if experiencing heartburn after meals or epigastric pain that is not relieved by antacids. See an eye specialist yearly to assess for development of cataracts. Use safety measures such as getting up slowly from bed or chair, and use good lighting to avoid accidental injury due to orthostatic hypotension. Maintain good hygiene practices and avoid contact with persons with cold or other contagious illnesses to prevent infection. Inform all healthcare providers about long-term corticosteroid use. Thus, in summary, primary hypofunction of the adrenal cortex or Addison's disease results in a reduction of all three classes of adrenal corticosteroids, namely glucocorticoids, mineralocorticoids, and androgens. Secondary disease results from pituitary dysfunction. The most common cause in the United States is autoimmune, where the adrenal cortex is destroyed by autoantibodies. Manifestations have a slow onset and include weakness, weight loss, and anorexia. Due to increased ACTH, skin hyperpigmentation is seen in exposed and unexposed areas of the body, at pressure points, over joints, and in palmar creases. Treatment is hormone therapy. Hydrocortisone is the most commonly used form of hormone therapy, as it has both glucocorticoids and mineralocorticoid properties. During times of stress, glucocorticoid dosage is increased to prevent Addisonian crisis. Mineralocorticoid replacement with fludrocortisone acetate or Florinef is given daily with increased dietary salt. Patients with Addison's disease are at risk for acute adrenal insufficiency, a life-threatening emergency caused by a sudden decrease in adrenocortical hormones. It is triggered by stress, example, surgery, trauma, psychological distress, sudden withdrawal of corticosteroid hormone therapy, and post-adrenal surgery. Manifestations include postural hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia, fever, weakness, and confusion. Treatment is shock management and high-dose hydrocortisone replacement. Large volumes of normal saline solutions and 5% dextrose are given to reverse hypotension and electrolyte imbalances until blood pressure normalizes. Treatment necessary for reducing the potassium levels as well as hydrogen receptor antihistamines are also given to prevent gastric irritation.